In wide local excision, the cancer is removed today, but the final margin answer usually comes from permanent section pathology later.
This explainer was written and edited by Dr. Thomas Hocker, a triple board-certified Harvard and Mayo Clinic-trained dermatologist, Mohs surgeon, and dermatopathologist.
Practical. Wait, so I have this surgery today, but I don't actually know if I'm clear until days later?
Section 1. Defining the three margins: precision and planning.
It's a very real concern, and answering it really starts with understanding that the word margin actually means three totally different things depending on where you are in the process. The physical reality of leaving the clinic without an immediate final answer makes perfect sense once we define these three margins: the clinical, the surgical, and the pathology margin. First up, we have the clinical margin. Before any surgery even begins, the surgeon measures a planned distance beyond the visible tumor or the biopsy site. This is a deliberate, normal-appearing rim drawn directly on the skin. It's crucial to understand that the word wide in wide local excision refers strictly to this careful oncologic plan. It absolutely doesn't mean the surgeon is just removing tissue without restraint. It's a precise measurement based on the specific type and the risk level of the cancer.
Expert. Next, we have the surgical margin. Think of this as the physical, three-dimensional block of tissue actually removed during the operation. It includes not just the outer edges on the surface of the skin, but also the deep border. To remove the cancer completely, this surgical margin has to include an appropriate deep layer, like subcutaneous tissue or even fascia, depending entirely on what the oncologic plan requires.
Finally, we arrive at the pathology margin. This is the specific part of that physical surgical border that is actually represented on microscope slides and eventually reported back as involved or clear. If this representative sample shows no cancer at the edge, it is called the negative margin. It's a representation of the edge viewed by the laboratory days later. Understanding the difference between the physical block of tissue removed today and the representative sample viewed on a slide later perfectly explains both the immense strengths and the inherent limits of this procedure.
Expert. Section 2. Step-by-step surgery. What happens in the room?
So how does this actually unfold for the patient? Let's walk through the exact sequence of events you'll experience in the procedure room on the day of your excision. First, the site and the planned clinical margin are marked out. Often, the shape is converted into an ellipse just to ensure the skin can be repaired safely. Second, anesthesia is administered. For a lot of these excisions, this is simply injected local anesthetic. You might feel a quick sting, followed by some pressure, but you remain completely awake. Third, the surgeon carefully removes the tumor and the planned deep layer. And fourth, this is a critical step. The surgeon orients the specimen. Using specific sutures, inks, or notches, they map exactly how that tissue sat in the body. If that final pathology report later comes back positive, this precise orientation tells the surgeon exactly where to go for a directed re-excision.
Section 3. The bread loaf pathology metaphor.
Once the procedure is done, your tissue's journey is really just beginning. We shift our focus from the operating room over to the laboratory to understand how the tissue is processed and why the final answer takes a few days. To understand standard pathology, imagine a solid stone block cut into a series of vertical slices. The pathologist examines the cut faces of those slices. This is standard representative vertical section sampling, informally known as bread loaf processing. It provides beautiful cellular detail, but unexamined tissue naturally exists between those cut faces. Contrast this calmly with Mohs surgery, which examines the properly processed peripheral and deep margin flat, or end face, with mapping during the operation itself. They are simply two entirely different ways of processing tissue.
Now, you might have heard a familiar claim floating around that standard excision only examines exactly 1% or 0.5% of the border. Well, we need to look at the evidence here. Treating those tiny percentages as a universal fact is just too simple and can actually be misleading. The actual fraction of the border examined depends heavily on the geometry of the specimen, how closely it's sliced, which blocks are submitted, and the specific laboratory protocol. It is representative sampling, absolutely, but it's highly variable.
Section 4. Comparing WLE and Mohs, choosing the right fit. Because we have two different methods of margin assessment, representative sampling later or end-face mapped assessment today, the clinical team has to choose the right fit for the specific cancer.
Okay, but if Mohs looks at the whole margin on the exact same day, why would anyone ever choose wide local excision over nose?
Wide local excision remains an incredibly strong, appropriate operation because permanent sections provide phenomenal, high-quality tissue detail.
It is an excellent definitive foundation for many well-defined basal and squamous cell carcinomas in favorable locations. And importantly, wide local excision with a thickness-based clinical margin remains the usual established surgical foundation for most invasive melanomas.
On the other hand, Mohs should be used when its specific advantages actually matter. Same-day, complete mapped margin assessment is generally the stronger choice for keratinocyte cancers that are recurrent, highly aggressive, poorly defined, or located in high-risk, tissue-sensitive, functionally important areas. In those scenarios, getting complete margin mapping while the patient is physically in the office genuinely changes and improves the care plan.
Practical. Let's do a quick reset here. If I'm having a wide local excision, and that final permanent section answer comes days later, what happens if a margin is positive? And honestly, can the wound even be repaired immediately today if we aren't 100% sure it's all gone? Expert. That is the pivotal reality of leaving the clinic. Let's look at exactly how wound repair timelines work, and what those final results actually dictate for you.
Section 5. Timing of wound repair, immediate versus staged.
The physical wound management is a direct response to the level of certainty we have and the type of repair required. This creates clear branches of decision-making for wound reconstruction. To reassure you directly, yes, many wide local excision wounds are repaired immediately on the very same day. This makes perfect sense when the surgeon judges that the expected chance of a positive margin is low. Like with a well-defined lower-risk tumor removed with an appropriate margin. And just to be totally clear, wide local excision absolutely does not preclude an immediate flap, graft, or complex repair if the surgeon is confident in the clinical plan. Immediate closure doesn't mean the final pathology is unimportant. It simply means the clinical team has decided the benefits of closing a straightforward wound today heavily outweigh the very small chance that the wound might need to be reopened later. However, the team will strongly consider a delayed or staged reconstruction if the tumor is highly aggressive, if clearance is uncertain, or if a major reconstructive flap is planned. The guiding rule here is very clear. The greater the cost of an uncertain margin, the stronger the reason to secure absolute clearance before performing a major tissue rearrangement. If finding a positive margin later would force the surgeon to sacrifice a complex reconstructive flap, leaving the wound temporarily dressed to wait for the final pathology report is definitely the safest path. Section 6. Understanding your final results.
Now, let's fast forward. It's been a few days, the laboratory has processed the permanent sections, and the final pathology report lands right on the surgeon's desk. What exactly does it say? The permanent sections provide excellent, detailed cellular information, usually resulting in one of 4 outcomes. You might see clear margins, which connects right back to that negative margin we defined earlier, meaning no tumor was seen at the representative examined edges. You could have close margins, where the tumor approaches but doesn't quite reach the edge. You could get unexpected higher-risk findings, like a deeper tumor or an aggressive subtype that completely changes the care plan. Or you might see positive margins.
If a margin is positive, it simply means tumor cells reach the examined cut edge of the specimen. It is incredibly important to understand that positive here describes the physical specimen edge. It does not automatically mean the cancer has spread to distant parts of the body. A positive margin just guides the next clinical step, which might be a directed re-excision using those exact orientation marks we discussed, transitioning over to Mohs surgery, utilizing another treatment like radiation, or involving multidisciplinary planning. Because this is a process that unfolds over a few days, it is vital to be prepared before you ever go into the procedure room. You really must ask your treating clinician 4 critical questions. How exactly will my margins be examined? When should the final results arrive? Will my wound repair be immediate or staged? And what is the specific plan if a margin actually comes back positive? Ultimately, the space between removing a tumor today and getting the final answer tomorrow isn't a flaw in the system. It's a calculated trade-off for microscopic precision. Dr. Hocker created Skin Trust to provide free, evidence-based dermatology education and help patients and clinicians make clearer decisions together. We invite you to read the complete Skin Trust article to review the full evidence and have an informed conversation with your clinical team. Up next, we'll be looking much deeper into the Skin Trust guidelines on invasive melanoma care.